This educational session is made possible through an independent grant from Forest. This program has been peer-reviewed, and the financial disclosures for advisory committee members, presenters, and planners are displayed on the following slides. By the end of this presentation, you will be able to discuss the intersection of inflammatory bowel disease with the menstrual cycle, fertility and pregnancy, cervical cancer, and menopause. You'll be able to counsel female patients with IBD on the optimal time to conceive and discuss the impact of active inflammation on fertility. And also discuss the management of IBD medication in the context of preconception and pregnant women. This presentation will be divided into the following sections. An overview of inflammatory bowel disease. We'll also discuss key takeaway points from Part 1, IBD and fertility and pregnancy, cervical cancer, menopause, and other health maintenance issues. We will also briefly discuss alternative approaches to IBD management, followed by a case study, question and answers, and summary. Let's move into an overview of the inflammatory bowel disease. It's an umbrella term used for Crohn's disease and ulcerative colitis. In the West, the incidence and prevalence of inflammatory bowel disease have increased in the past 50 years. As many as 1.4 million in the United States and 2.2 million people in Europe suffer from IBD. In North America, the annual incidence of Crohn's disease was 20.2 per 100,000 person years, and the annual incidence of UC was 19.2. In terms of prevalence, the highest reported prevalence values for IBD in North America was 319 per 100,000 persons. IBD is a chronic idiopathic disease characterized by the tendency of chronic or relapsing activation of the immune system within the GI tract. Although both Crohn's disease and ulcerative colitis conditions present very differently, they involve different parts of the GI tract. For example, Crohn's disease may involve anything in the GI tract from mouth to anus, and it usually involves discrete areas of diseased bowel separated by normal bowel, known as skip lesions. Ulcerative colitis involves continuous mucosal inflammation that starts in the rectum and extends proximally. Typical symptoms of UC are bloody diarrhea, abdominal pain, urgency, and tenesmus. The predominant symptoms of IBD can include diarrhea, abdominal pain, GI bleeding, weight loss, malnutrition, and fatigue, and can have substantial psychosocial implications and negatively impact overall quality of life. A survey of the impact of other chronic conditions on the quality of life of patients with IBD showed that IBD patients scored lower on the SF-36 mental health scale than did patients with any other of 4 other chronic conditions. Additionally, bowel symptom severity contributed the most to the health-related quality of life in IBD patients. A multitude of women's health issues are affected by IBD, which in turn have impact on the overall quality of life and include the menstrual cycle, contraception, conception, fertility and pregnancy, menopause, mood and sexuality, and relationships. Some summary of takeaway from Part 1 was we found that IBD impacts numerous aspects of women's health and quality of life. IBD may delay menses and cause menstrual abnormalities. The optimal contraceptive method for women with IBD should have low failure rate and minimal interference with disease. It is very important for women with IBD to plan pregnancy, ideally when disease is in remission for at least 3 to 6 months. We will now explore the last point more in depth. So talking more about important considerations and issues related to fertility and pregnancy in IBD, again, we want to emphasize the importance of planning a pregnancy. We're moving into a poll first. So have you cared for a woman with IBD in the past year? Please answer yes or no. Okay, so it's 58% have not and 42% yes. I think we have one more polling question here. For those of you who have cared for a woman with IBD, did you ask her about her fertility plans, yes or no? Okay, so about 2/3 of participants said that they did not ask about fertility plans. And so now we'll move into the importance of that discussion with your patients.
So women with IBD should plan a pregnancy, and this is really important compared to women without a chronic disease. Having IBD does not necessarily affect the ability to conceive, and with careful supervision by both a gastroenterologist and an OBGYN, most women with IBD can have a healthy pregnancy and a healthy baby. But there are some important considerations for women with IBD, and the importance of planning the pregnancy is a consideration to discuss with your patients. Now, the reason this is important is that half of all pregnancies in this country are unplanned. And for a woman with IBD, if she's faced with an unplanned pregnancy at the time when her disease is active, she's more likely to have recurrent flares in pregnancy, miscarriage, preterm delivery, low birth weight, and in addition to this, other adverse outcomes with unintended pregnancy, such as adverse mental health and physical outcomes in the baby. One of the ways that we've proposed in the family planning community to talk to patients about their desire for fertility is the one key question, which was developed by the Oregon Foundation for Reproductive Health. And this is really targeting primary care providers, but also medical subspecialists and reproductive health providers to ask every reproductive age woman every time, would you like to become pregnant in the next year? And so for those women who say yes, or for those who are uncertain of whether they want to become pregnant or not, we get them on folic acid supplement, make sure that their chronic condition is managed, that their medications are safe, and really get them to act pregnant before they're pregnant. Whereas those who say no, or they're uncertain but want to prevent a pregnancy, at this point, we talk to them about the importance of highly effective contraception. Now, whose job is it to talk to patients about family planning when they have IBD? And this is a difficult one because most patients are not seeing an OBGYN on a regular basis unless they're pregnant or have a problem. And so they're more likely to see their primary care provider or their gastroenterologist if they're having active management issues with their IBD. When you ask women with IBD who they would like to give information to them about family planning and pregnancy, they talk about their preference of their gastroenterologist or their PCP giving this information over their OBGYN. But unfortunately, most IBD patients are not going to initiate this conversation, and so it's really up to the provider to talk to the patient about these issues and initiate the conversation and visits. So in addition to considering the issue of timing of pregnancy, ideally when disease is in remission for 3 to 6 months and the patient's not taking steroids, it's also important to consider prevention of unplanned pregnancy when a new medication is being started for IBD, because we're not entirely sure how that's going to work and whether it's going to control her symptoms as well. And it's also important to check the activity of IBD. So even if a patient is stable on her medications, if she's having some recurrent flares in this, then we need to discuss contraception and potentially reconsultation with a gastroenterologist to optimize her medication and get her disease under better control before pregnancy planning. Now, this is a list of important preconception issues to address. And in the previous webinar, we talked about heritability, disease, and nutritional needs. I'm going to go more in depth about medications and surgical considerations. But first, let's talk more in depth about fertility and IBD. Generally speaking, women with Crohn's disease or ulcerative colitis, when they have their disease in remission, can become pregnant as easily as other women of the same age. But there's a misperception in women with IBD that they have a decreased fertility and that it might be more difficult to become pregnant. Now, this may be true for women with more active disease or some surgical considerations that we'll go more into detail about later. This misperception can actually affect contraception use. If a woman thinks that it's harder for her to get pregnant, she may not be as proactive about preventing pregnancy. When we do research on fertility issues in IBD, it's a hard topic to address because there have been some previous studies that have shown that women with IBD are more likely to have voluntary childlessness, or they didn't intend to get pregnant because of their disease. Now, some of these studies are older, and these are all small cohort sizes, but voluntary childlessness is an important consideration when you look at population-level studies of fertility. So what are the fertility rates in women with IBD versus women without IBD? What data do we have to talk to our patients about the importance of preventing pregnancy and getting rid of the myth that they have a perceived infertility issue so that they can prevent it? Now, fertility rates in women with IBD versus without have been shown to be approximately the same. We do see some subfertility following IBD flares and also following certain surgeries, but overall, before diagnosis versus after diagnosis, fertility stays the same in women with IBD. In order to look at this at a larger scale, a meta-analysis was done to evaluate the impact of IBD on fertility in both women and men with IBD who had no history of surgical treatment. There were 11 studies that were included in this meta-analysis, and they showed a range of 17 to 44% reduction in fertility in women with Crohn's disease compared with controls. But what they found is that reduction in fertility was linked to voluntary childlessness, and that there was no physiological cause of infertility. Additionally, most studies did not find any reduction in fertility in women with ulcerative colitis as compared to controls. So these results really reinforce the finding that IBD does not in itself lead to infertility. Now, there is one surgical consideration that can potentially affect fertility, and that's called an ileal pouch anal anastomosis, or an IPAA procedure. This procedure is most commonly performed for ulcerative colitis, and it can actually be curative by removing the large intestine. The benefit of it is that it eliminates the need for an ostomy bag or a permanent appliance. During the IPAA surgery, the patient's large intestine is removed, and the small intestine is then connected to the anus. The last few inches of the small intestine are used to create an internal pouch which serves the function of the rectum. So this preserves the anus and creates a new storage place for stool. And so patients are able to maintain control over their bowel habits. But one of the concerns about this surgery is the intense pelvic dissection that happens during this that could potentially affect fertility. And this is a list of many studies that have been done trying to look at infertility rates in women with ulcerative colitis who were medically managed versus those who had the IPAA procedure. And all of these studies did show a reduction in fertility after the procedure. But many of these studies, as you can see, had very low numbers of participants. And they also included patients who had the procedure for reasons other than ulcerative colitis. Additionally, they didn't always take into consideration voluntary childlessness. And only one study actually looked at hysterosalpingograms to assess whether the tubes were open. And they only did this after the surgery, not before, to assess whether this was related to a previous infection or ulcerative colitis, or if it's truly related to the surgery itself. And so there's a lot of research that needs to be done in this area. But for those women who do truly have the diagnosis of infertility, it's important to talk to them about what IVF could do for them and whether it would be successful. And this was one study that was done retrospectively, looking at patients from 1998 to 2011 to investigate the success of IVF in patients with IBD compared to the non-IBD population. And what they found is that patients with IBD do not have inferior rates of live births after IVF. And so they have just as much success with assisted reproductive technology as those without the disease. In patients who have had the IPAA surgery done, another study was done to look at IVF success rates. And again, we found no difference in success between those patients who had an IPAA and those who had medically managed ulcerative, those who truly have infertility in the setting of IBD to have successful treatment. So switching topics, another issue of consideration for women with IBD is around the mode of delivery for patients who have had an IPAA procedure. And there's really a lack of consensus on the timing and recommended mode of delivery for patients after their surgery has been done. And part of this confusion is because of inconsistent recommendations coming from different providers. Gastroenterologists, OBGYN, colorectal surgeons are all giving patients different information on what the risk of infertility is, when they should deliver, whether they should have a C-section versus vaginal delivery, and who should really be calling the shots about the delivery decision. And so it's really important to come together as a team when you're taking care of these patients so that the patient is getting consistent recommendations about her delivery management. Now, most of these patients after IPAA can have a vaginal delivery. There is some concern about obstetrical tears affecting the anal sphincter and potentially the risk of incontinence after that. And so maybe considering avoidance of operative delivery if a vaginal delivery is trialed. But at the same time, this recommendation needs to be individualized and a team effort. Another area that patients want more information on is medication considerations during pregnancy. And this is confusing because a lot of primary care doctors and OBGYNs don't commonly prescribe these medications or know what classes that they fall in. And so it's important to remember that really the only two medications that are contraindicated during pregnancy that are used in IBD treatment are methotrexate and thalidomide, and they're not even commonly used for patients anymore now that biologic agents are more available. And so for most patients, they're on medications that are safe for pregnancy. We have increasing data showing that safety in a large prospective trial called the PIANO trial. And finally, it's really important to talk to patients about not stopping their medications. Patients are very concerned when they have that positive pregnancy test about their medications and what that means, especially if they weren't planning for the pregnancy and hadn't previously talked to their doctor. And so it's important to counsel them about not stopping their medications, because if they stop them and their disease flares, they're more likely to have an adverse outcome than if they would have continued the medications and just talked to their gastroenterologist. One other consideration that women often have is what happens to their surgical outcome if they become pregnant, and what do these surgeries do for their pregnancy risks going forward. So we don't see any apparent negative effects from previous bowel resections or from the ilioanal anastomosis on pregnancy. Again, there is that potential slight decrease in fertility for women after IPAA. Some women who have had an ileostomy may experience a prolapse or obstruction during pregnancy, although this is a rare complication. And finally, the issue of perianal fistulas or abscesses needs to be considered for patients who have active disease. They may require a C-section at this point in order to avoid worsening of their disease or a larger obstetrical tear. But again, this is an individualized discussion. And finally, I just want to briefly talk about the risks for congenital anomalies associated with IBD. Many women with IBD have concerns about their disease or the medications that they're taking and the risk to their baby. But again, it's important to talk to your patients about the safety of these medications during pregnancy and how it's worse to stop the medications and flare than it is to continue them. And in studies that have followed patients longitudinally and looked at outcomes in their offspring, the investigators found no evidence that IBD during pregnancy or medical therapy for IBD during pregnancy increases the risk of a major congenital anomaly in children.
We have covered a number of important aspects specific to the care of the female patient with IBD, but there are several other important issues such as cervical cancer prevention, vaccination considerations, bone loss and osteoporosis, menopause, and psychological issues. It is somewhat unclear whether there is a link between IBD and vulnerability of cervical cancer. A national cohort of women diagnosed with Crohn's disease and ulcerative colitis were examined for the risk of cervical neoplasia. Patients with Crohn's disease had an increased risk of cervical cancer compared to with controls. A larger meta-analysis was conducted to assess risk of cervical cancer in patients with IBD on immunosuppressive therapy. The results of this analysis demonstrated that there was an increased risk of high-grade cervical dysplasia and cervical cancer among patients with IBD who are on immunosuppressive therapy. Specific risk factors for cervical cancer include chronic inflammation, a longer duration of disease, diagnosis of primary sclerosing cholangitis, and pancolitis. In terms of screening for cervical cancer in IBD, the updated guidelines were published in 2012 by the American Society for Colposcopy and Cervical Pathology in conjunction with the American Cancer Society and the American Society for Clinical Pathology. As noted in this table here, there are no screening recommendations no screening is recommended for women under 21 years of age. Cytology alone is recommended every 3 years for women 21 to 29 years of age, and cytology alone every 3 years is acceptable in women 30 to 65 years of age. However, HPV and cytology co-testing every 5 years is preferred in this population. I would like to emphasize that HPV testing is not recommended for screening in any of the age groups. It is also important to be aware of the potential limitations of these guidelines in immunosuppressed patients, especially those with high-risk sexual behaviors. In such patients, screening may need to be individualized and may need to be more frequent for some of these patients. Approximately 70% of cervical cancer cases worldwide are caused by HPV types 16 and 18. There are currently 3 vaccines available in the U.S. that protect against HPV 16 and 18. In 2015, the Advisory Committee on Immunization Practices specified routine HPV vaccination at age 11 or 12 and HPV vaccination for females aged 13 to 26 who are not vaccinated for HPV previously. Given the risk of abnormal pap smears, women on chronic immunosuppressive therapy are also candidates for HPV vaccination, regardless of sexual history. Treatment regimens for IBD, particularly immunosuppressive agents, increase the susceptibility to infections that may be prevented by vaccinations. In particular, patients are at risk of opportunistic infections, viral hepatitis, potentially life-threatening pneumococcal pneumonia, and disseminated varicella. Several studies have demonstrated that patients with IBD are under-vaccinated. Furthermore, there appear to be a significant knowledge gap among gastroenterologists regarding which vaccinations should be given to patients with IBD. With this information, it is very important to educate the IBD patient as well as the providers who are treating them about the importance of vaccinating this at-risk population. This table summarizes major vaccines that are indicated and contraindicated in patients with IBD. So in general, adults with IBD should be advised to adhere to standard recommended immunization schedules, but those that are on immunosuppressive therapy should avoid live vaccinations. Wasson and colleagues conducted a study, an electronic study on 1,000 gastroenterologists to assess the knowledge regarding vaccinating the IBD patient. Of 108 responders, 52% asked their patients about immunization history most or all of the time. 64% believed that the PCP should be determining which vaccinations to be given, and 83% believed the PCP should be administering those vaccinations. Overall, 66% to 88% of gastroenterologists correctly recommended the inactivated vaccines for their IBD patients not on immunosuppressive therapies, while 20 to 30% incorrectly recommended administering live vaccine to their immunosuppressed patients. The results of this survey underscore some gaps in the gastroenterologist's knowledge of appropriate immunizations to recommend to their IBD patients. Switching gears here to bone loss in IBD, patients are at high risk for developing osteopenia and osteoporosis. As many as 30 to 60% of persons with Crohn's disease or ulcerative colitis have lower than average bone density. The prevalence of osteopenia and osteoporosis in patients with IBD varies significantly, depending on the study population, the location, and the design, but it ranges from 22 to 77% with osteoporosis and 17 to 41% with osteopenia. Causes of bone loss in IBD include corticosteroid therapy, inflammation, and vitamin D deficiency. It is believed that 30 to 50% of people who take corticosteroids on a long-term basis develop osteoporosis. Corticosteroids impair formation of new bone by decreasing the amount of calcium absorbed by the intestines from food, increasing the elimination of calcium in the urine, stimulating the production of osteoclasts, decreasing the number of osteoblasts, and reducing the production of estrogen, which contributes to bone strength. Persons with Crohn's disease are at increased risk for vitamin D deficiency, which may result in bone loss and osteoporosis. In terms of risk factors, increasing age, female gender, low body mass index are all contribute to greater risk for bone loss in the patient with IBD. Smoking and alcohol consumption also increase the risk of bone loss in IBD. DEXA scan is the most widely used method for diagnosing osteoporosis in adults. The World Health Organization Fracture Risk Assessment Tool, or the FRAX, is a free web-based clinical scale that assesses the 10-year fracture risk and need for lifestyle advice, DEXA scanning, or preventive treatment. In a study that applied the FRAX to predict the need for DEXA scanning and treatment in at-risk IBD patients, the clinical FRAX score alone was found to accurately predict the risk of osteoporotic fracture and reduce the need for DEXA scans and unnecessary treatment. All women with IBD are at risk for osteoporosis and should be counseled about important lifestyle modifications. These include a balanced diet with optimal amounts of nutrients, abstaining from smoking and restricting alcohol consumption, and exercising regularly with weight-bearing exercises. Whereas high-dose vitamin D3 supplementation in IBD patients with active inflammation or during a flare may be detrimental to bone health, but supplementation of vitamin D at lower doses at 2,000 to 5,000 international units per day after inflammatory activity has been suppressed may be given. Calcium intake should be about 1,000 to 1,500 milligrams per day. Vitamin K intake to 80 to 100 per day is adequate. There is some clinical evidence that should suggest that bisphosphonates are effective in patients with steroid-induced bone loss. Although biphosphonate therapy has been beneficial in the general population with Crohn's disease or ulcerative colitis, there are some potential complications that you need to keep in mind when prescribing biphosphonates. These complications include osteonecrosis of the jaw and paradoxical increased risk of fractures. So the use of biphosphonate should be limited to steroid-dependent patients with proven osteoporosis and postmenopausal women with IBD. Unfortunately, minimal data is available on the effect of IBD on women in menopause. However, women may be diagnosed with IBD after the onset of menopause, so it is essential to monitor the symptoms of IBD in light of hormonal therapies, in light of hormonal changes associated with menopause. The effects of hormone replacement therapy on IBD are somewhat unclear as well, although one study by Kane et al. Did show a protective and dose-dependent effect of HRT in women with IBD. Another study completed by Colitis et al. Did show a correlation between hormone replacement therapy and an increased risk of UC development, but this correlation was not seen with Crohn's disease. Although psychological influences were not recognized in the past as contributing to IBD, there is evidence for the role of psychological stress in IBD. Stress appears to be a triggering and exacerbating factor in the course of symptoms of IBD and may be considered one of the detriments of disease relapse. IBD can cause a wide range of psychological and interpersonal concerns for patients. A recent study has come to the conclusion that there are higher rates of anxiety and depression in this patient population. As I stated before, anxiety and depression can have a detrimental effect on the course of IBD. Depression in particular has been found to have a detrimental effect on disease course with a greater likelihood of more frequent or earlier relapses. There is evidence of significantly poor adherence to treatment regimens by individuals with a comorbid psychological disorder. Incorporating brief screening questions to the office visit that ask about coping and about symptoms of anxiety and depression can be helpful in flagging these issues. Some of the questions include, have you been coping recently, or do you experience problems with stress and anxiety or worry? Have you felt down or depressed most of the day, or do you find that you have decreased interest in the things that you usually enjoy? As shown in this algorithm, managing anxiety and depression in the IBD patient begins with screening. The primary care provider or the gastroenterologist who is managing the IBD patient should initiate pharmacological therapy or refer to a mental health specialist depending on the preferred treatment approach. The IBD clinician should provide follow-up within 6 to 8 weeks after starting treatment for anxiety and depression. Relationship concerns to address in IBD also include fatigue, interference of medications with sex, and painful sex, and feeling unattractive. A number of alternative approaches to the management of IBD are now being used, so I'm going to briefly discuss some of those in the next slide. Complementary and alternative medicine comprises a group of diverse medical and healthcare systems, practices, and products not presently part of conventional medicine. Concurrent use of complementary medicine is about 11 to 34% in IBD patients in North America and Europe. This integrative concepts of these alternative approaches include stress, inflammation, diet, nutrition, and hormones. Now I'd like to introduce you to Maya. Maya is a 27-year-old female diagnosed in 2013 with ileal and perianal disease, and she status post small bowel resection. She has been treated with a biologic infusion called infliximab and was not responding to therapy and was found to have. She was then transitioned to another biologic called adalimumab, and 3 months ago, she presents to your clinic for preconceptual counseling and health maintenance. How would you counsel this patient on preconceptual planning? We're going to launch the poll now. How do you counsel this patient on preconceptual counseling? Discuss pregnancy with both the OBGYN and gastroenterologist, transition off of methotrexate, ensure disease control, start a prenatal vitamin, or all of the above. Perfect, all of the above. Maya read on the internet that she needs pap smears every 6 months because women with IBD have an increased risk of cervical cancer. What would you recommend? Every 6-month pap smears, co-testing every 5 years, pap screening that is no different from healthy women, or review of her pap results and sexual history to guide pap smear frequency. I would recommend that we review her pap smear results and sexual history to guide pap smear frequency. Last question, which of the following vaccines is contraindicated while she is immunosuppressed? The recommendation is to actually avoid all live vaccines when patients are on immunosuppressive therapies. And now we'll turn the time over for some questions and we'll try to answer them.
Great, thank you very much. At this time, we'll move on to the Q&A section. If you have any questions, please type them into the question box on your screen.
There is one question that says, are there any lifestyle changes in regard to IBD and pregnancy? And the lifestyle changes are really no different than for women who don't have IBD. You know, it's important, as we discussed, to have their IBD under control. So we do discuss frequent visits with gastroenterologists to check in and make sure that the medications are still appropriately managing their symptoms. And also, I always recommend monitoring their symptoms to assess for subtle changes. But as for lifestyle changes, we still talk to them about the importance of exercise, especially weight-bearing exercises in general, given their risk of osteopenia and osteoporosis. And normal pregnancy considerations for exercise restrictions would apply. But otherwise, weight gain is an important topic that we talk about, getting a variety of food sources, taking their prenatal vitamin, potentially calcium and vitamin D supplement, and closely monitoring their weight gain throughout pregnancy, because weight loss or poor weight gain can be a sign of active IBD. How do you counsel a patient who is in the midst of an IBD flare but really wants to become pregnant? This is an important question because many of us who are planning pregnancies really have a time in our lives that it works out best to become pregnant. For those of us in medicine, there might be a time between training or a new job where it's really important, and this is true for patients outside of medicine as well. And so it's hard to tell a woman who it's the optimal time socially to become pregnant that she shouldn't become pregnant. But I always talk about the increased risk of adverse pregnancy outcomes. Most women who, for example, have Crohn's disease, 83% of them will have a normal pregnancy course, which is the same as the healthy population if their disease is under control, whereas only 54% of them will have a normal pregnancy course if their disease is flaring. So they have an increased risk of preterm delivery and double the risk of miscarriage. And so we talk about planning for pregnancy when their disease is under control and getting their flare managed and waiting 3 to 6 months after that before pregnancy planning. The question is infusion therapy safe, IVIG, for this population? IVIG is not commonly used for IBD treatment as it is in other medical conditions. There are certain infusion therapies that are biologic agents that have to be infused as opposed to injections or oral medications. But IVIG is not a common medication for IBD treatment. And as for the other infusion therapies, there are some of them that the dose may be altered or the frequency of the dosing may be altered depending on patient response, and that might change during pregnancy, but otherwise safety is not a consideration.
No, the calcium intake recommendations. So the question is, are calcium intake recommendations for women with IBD during pregnancy different than routine recommendations? No, they're not. The recommendations for calcium is 1,000 to 1,500 milligrams per day.
Any other questions?
Yes, if you have any other questions, please enter it into the question box on your screen, and we'll give it a couple of minutes. All right, looks like that's all the questions we have for today, so we'll move on to the summary statement.
So in summary, IBD impacts numerous aspects of women's health and quality of life. It is very, very important that women with IBD plan pregnancy, ideally when the disease is in remission for at least 3 to 6 months. Fertility in women with IBD can be affected by inflammation in the IPAA procedure. Immunosuppressive therapy may increase risk of cervical dysplasia in women with IBD, and women with IBD may require more frequent screening interval for cervical cancer and may need to be judged and discussed on a day-to-day or on a person-to-person basis. Women with IBD should be counseled to adhere to standard immunization schedules, and live vaccines should be avoided with immunosuppressed patients. IBD association with risk of bone loss is very high and should be addressed as well. High rates of anxiety and depression in women with IBD warrant consistent screening questions and routine office visits. It is essential for the gastroenterologist and the primary care providers to address relationship issues related to IBD with their patients and refer appropriately.
Great, thank you very much. And thank you all for being here. We'd like to give another special thanks to our presenters for their excellent overview of this topic. Within an hour, you will receive a link to the post-test. Please complete this form to receive your continuing education credits. Thank you again, and we hope you will join ARHP for other educational sessions.